Good morning, everyone, and welcome to another session of TIRO by MDs. I am Camilo Gonzalez Velasquez, and it's truly my honor to be your host for what promises to be a very insightful session. Today, we have the privilege of hearing from Dr. Herbert Chen and Dr. Zhixing Song, who will be presenting their group's work and recent publication on incidentally found thyroid nodules on computed tomography. This study is crucial as it helps us understand the prevalence of these nodules, their risk of malignancy, and the global trends in their follow-up. First, I'd like to introduce Dr. Herbert Chen. Dr. Chen is the chair of the Department of Surgery at the University of Alabama at Birmingham, surgeon-in-chief of the UAB Hospital and Health System, and editor-in-chief of the American Journal of Surgery. He's a leading endocrine surgeon and researcher, renowned for pioneering radio-guided parathyroid surgery. Dr. Chen has published extensively in well-renowned journals and has been mentor to over 150 trainees. We are delighted to have such a distinguished expert share his insights with us today. Joining Dr. Chen for the presentation, we have Dr. Zhixing Song, who comes to us from Shanghai, China. Dr. Song brings a passion for clinical outcomes research and health informatics, aspiring to become an academic surgeon who blends cutting-edge research with patient care to improve surgical outcomes and advance the field. We look forward for his contributions to this important discussion. Finally, joining us as our expert discussant is my honor to introduce Dr. Michael Starc. Dr. Starc is an associate attending neuroradiologist at the Memorial Sloan Kettering Cancer Center, specializing in head and neck oncology. His clinical focus includes thyroid disease management, team imaging review, and his current research interests involve using imaging after neoadjuvant therapy in head and neck oncology to guide optimal surgical and clinical management. Dr. Starc's expertise will undoubtedly provide invaluable insights to the imaging aspects of incidentally found thyroid nodules. Before we hand the mic over to Dr. Song, I'd like to invite all of our audience to tune in to Voices of Wisdom. Voices of Wisdom is a podcast that the THANC Foundation and the TIRO group has put together, bringing clinical pearls to thyroid cancer diagnosis and management. These are hosted by Dr. Dana Hartle, and we have a international panel of hosts that join these sessions, and you can watch them on your favorite podcast platforms. Also, I'd like to invite all of our audience to please send in any questions before about the presentation, and we will try to get to as many of them before the hour hits. And we'll also like to distract your attention for just a moment to please register and attend the World Congress of Thyroid Cancer. This is going to be a very, very interesting and very, very insightful meeting up in Boston coming up in mid-July. So without any further ado, Dr. Song, the floor is yours.
Thank you so much for the introduction, Dr. Gonzalez. I'm very excited to share the work this morning from a team that I was part of, led by Dr. Chen. I also want to thank the Thyroid Head and Neck Foundation for giving us the opportunity to present this study. The paper we're discussing today is the Incidentaloma paper published in the journal Thyroid last year. It was a collaborative effort, and I would like to thank my mentor, Dr. Chen, and all the co-authors for their contribution. We have no disclosures. For our discussion today, I'll follow this outline. I'm going to provide some background about the definition of incidentalomas and the current management strategy for them. We'll then get into the methods of our study, talk about how we design our meta-analysis. We'll then discuss the results, including prevalence of thyroid incidentalomas, follow-up, and risk of malignancy of incidentalomas found on CT. We'll finish discussing about a few strengths, limitations, as well as clinical implications of our study. Let's begin by familiarizing ourselves about the definition of thyroid incidentalomas. A thyroid incidentaloma is a nodule discovered incidentally during an imaging study or surgery that is unrelated to thyroid gland. They carry the same risk of malignancy as a clinically found thyroid nodules, which ranges from 1.1% to 5%. There are multiple imaging modalities on which incidentalomas could be found. For example, ultrasound is the first-line imaging modality frequently used to guide biopsy. However, its limitation is that it cannot see very deep structures. CT scan shows incidentalomas in about 15% of the time. CT is good at detecting deep structures, and it's also often done for unrelated reasons like trauma and lung cancer screening. MRI is not the most commonly performed study for thyroid, but it offers great soft tissue contrast. PET has the lowest prevalence. Incidentalomas show in about 2% of them. However, these PET-avid nodules do carry a much higher malignancy risk, around 30%, so they are clinically significant when found. After the incidentalomas were detected on imaging, the next question is, should they be worked up? Well, that depends. So different societies have different guidelines. So this table compares two major sets of guidelines, those from the American Thyroid Association, ATA, or the American College of Radiology, or ACR, both published in 2015. The ATA recommends further follow-up for nodules that are greater than 1 centimeter. Smaller nodules less than 1 centimeter should only be evaluated if they're associated with symptoms or cervical adenopathy. The recommended follow-up included thyroid function test and ultrasound. The ACR, on the other hand, bases its criteria primarily on imaging features and patient age. So if a nodule shows highly suspicious features, then it warrants follow-up. For younger patients under 35 years, nodules nodules greater than 1 centimeter should be evaluated, and for those who are over 35 years old, the threshold rises to 1.5 centimeters. The ACR recommends ultrasound as a follow-up. Because of the differences in society recommendations, we sometimes see two extremes in clinical practice. Some nodules are inadequately followed up, and others may be overdiagnosed and overtreated. So these two studies help illustrate the two ends of the spectrum. On the left, our own study showing that a loss of follow-up in underserved populations, and on the right, Dr. Jensen's study highlighted overtreatment in cases of low-risk thyroid cancers. Together, they emphasize the need for more robust, evidence-based, and standardized guidelines for managing thyroid incidentalomas. Now let's shift our focus to CT imaging. In the last decade, we've seen a dramatic rise in the number of CT scans that were performed, driven largely by the COVID-19 pandemic and the expansion of lung cancer screening program. So this explosion in CT imaging offers us a unique opportunity, a large, relatively untapped data set of thyroid incidentalomas captured across diverse populations and clinical contexts. The question now becomes, can we use this data not just to measure how many incidentalomas were discovered, but also to assess how they were managed? Were these nodules appropriately evaluated and followed up? Were some patients lost in the system while others were potentially overtreated for a low-risk disease? So these are the questions that led to the aims of our meta-analysis. First, we wanted to examine the follow-up and risk of malignancy in thyroid incidentalomas found on CT. Our goal was to test the validity of the existing guidelines and to better inform clinical decision making. Secondly, we set out to explore the overall prevalence of thyroid incidentalomas on CT. We hope that this would give us a clearer picture of the disease burden these incidentaloma represents. We used a systematic review and meta-analysis approach to answer our research questions. A systematic review identifies and evaluates all relevant studies on a topic, while a meta-analysis quantitatively combines the results into a more robust generalizable conclusion. As you can see on the left, meta-analysis and systematic review is at the top of scientific hierarchy, and our review was prospectively registered on Prospero. We conducted a comprehensive search on April 12th, 2024, using PubMed, Embase, and Cochrane libraries. Our search terms included thyroincidental and computed tomography, and we included studies up to that date. We selected cohort studies and RCT reporting the prevalence, follow-up, and malignancy of CT incidentalomas. We excluded non-English papers and studies that didn't isolate CT findings from other imaging modalities. We extracted details information about from each study, such as the publication year, sample size, region, and patient characteristics, as well as some technical CT details like the slice, thickness, use of contrast, and whether the scan covered the neck or chest. We also noted the average size of the incidentalomas in the clinical context, whether they were being performed for lung cancer screening, COVID-19 trauma, or other reasons. Finally, we also recorded the incidentalomas, how they were identified. So in some studies, the incidentalomas were extracted from radiology report directly through keyword-based filters. In other studies, a radiologist or more, so they would actively reread the CT images specifically to look for incidentalomas. So these two approaches differ in sensitivity and likely contribute to the variation of reported prevalence. We assessed the study quality using the NOS scale and the ROB2 scale. To pull the data across studies, we use the random effect model, which accounts for variability across studies. We assess the heterogeneity using the I-statistics, I-squared statistics. The higher the value, it indicates the more variability that cannot be explained by chance alone. To explore the source of the heterogeneity, we also performed a multivariate meta-regression, looking at study and nodule level factors. Lastly, we assessed the publication bias using the Eggers and Beggs tests. The initial database search retrieved 916 papers. An additional 2 were identified through other sources. After removing the duplicate papers and screening the rest of the paper by title and abstract, ultimately we found 49 studies that met our inclusion criteria. The 49 studies we included totaled over 230,000 patients. Most of these studies were cohort studies, and the average age of the population was 56 years, and the female percentage was 55%. In terms of why CT were performed, 41% were for other reasons, 16% for trauma, 10% lung cancer screening, and 8% COVID-19. About 45% of the scans focused on the chest, 26 on the neck, and the rest either included both or didn't specify. CT thickness ranged from 0.75 to 5 millimeters. Then 45% of the study used contrast-enhanced studies. The mean size of the incidentalomas ranged from 0.6 to 3 centimeters across studies. As of how the incidentalomas were identified, almost 60% relied on keyword-based extraction, and another 40% involve radiologists re-evaluation of the images. Lastly, in terms of study quality, a majority of the cohort studies were rated as low risk of bias. So 38 studies involving more than 190,000 patients reported the prevalence of thyroid incidentalomas on CT imaging. The polled prevalence was 8.3% with substantial heterogeneity. Eggers and Begg's test did not suggest publication bias. To better understand the variability in the prevalence estimates, we conducted subgroup analysis based on four factors: the identification method, the use of contrast, CT region, and the scan indication. So we found that the prevalence was higher when incidentalomas were identified through radiologist re-evaluation compared to report extraction. And so 13.4% versus 5.2%. With contrast enhanced CT, the prevalence was 11.5% compared to 5.5% for non-contrast scans. For CT regions, neck scans showed a notably higher prevalence at 16.5% compared to 6.6% for chest CTs. And when stratified by scan indication, incidentalomas were more frequently found on CTs done for non-screening purposes, such as general workup, trauma, and COVID-19 evaluation. Of these, only the CT region showed a statistically significant difference with a meta-regression p-value of 0.028. The other comparisons, despite the trends, did not reach significance. 11 studies reported imaging characteristics of almost 2,000 patients with CT thyroid incidentalomas. We looked at three key features: whether the incidentalomas were multiple and whether they were bigger than 1 centimeter or 1.5 centimeter in diameter. We found that about 27% of the patients had multiple incidentalomas on CT, and nearly half of them had at least a nodule that is measuring 1 centimeter or greater. And about 29% had a nodule that was 1.5 centimeter or larger. 16 studies reported follow-up data for 2,683 patients with CT detected thyroid incidentalomas. We examined three types of follow-up actions, including the ultrasound, biopsy, and surgery. The ultrasound was the most common, performed in about 35% of the patients. Biopsies were done in roughly 28% of the cases. Thyroid surgery was required in 8% of the patients. Next, we evaluated the risk of malignancy in CT incidentalomas. 25 studies reported malignancy data for 6,272 patients. The pooled malignancy risk was 3.9% and was a 95% confidence interval from 3 to 4.9%. There was substantial heterogeneity across studies. Both Eggers and Beck's tests did not show publication bias. Again, we conducted subgroup analysis based on four factors: the CT region, contrast use, patient age, and study bias rating. So malignancy risk was slightly higher in neck CTs compared to chest CTs, 6.5% versus 3.6%. And patient scanned with non-contrast CT had a malignancy rate of 5.5% compared to 3.6% for those with contrast enhanced CTs. When stratified by age, patients under 60 years old had a higher malignancy rate, 12.5% versus 3% in those 60 and older. And finally, studies rated as low risk of bias reported higher malignancy risk, 9.1% versus 1.8% from high-risk studies. We also examine how malignancy risk varies by nodule size. When we so for nodules that were 1 centimeters or above, the pooled malignancy rate was 11.7%. In contrast, nodules smaller than 1 centimeter had a malignancy rate of just 0.1%. When we raised the threshold to 1.5 centimeter, which corresponds to the recommendation of ACR, so the risk increased even more. Nodules greater than 1.5 centimeters had a malignancy risk of 24.9%, and those smaller than 1.5 centimeter had essentially no observed malignancy with a pooled rate of 0%. These findings support that what clinical guidelines suggest that size is a strong indicator of malignancy. Um, it's a useful guideline and it is an important characteristic. Our study offers several key strengths. First, we included a large data set over 230,000 patients from 49 studies, allowing for precise estimates and strong statistical power. Second, we performed very detailed subgroup analysis based on how patient demographics and nodule characteristics. It helps to explain heterogeneity and in the prevalence and malignancy risk. Thirdly, we incorporated the follow-up and treatment data, which are rarely included in prior meta-analysis. This gives us a more complete picture about how incidentalomas were managed in real-world practice. Our study do have a few important limitations. So we observed substantial heterogeneity, partly because of the difference in CT body regions and the definition of thyroid incidentalomas. Secondly, selection bias was a concern. Some studies included all patients undergoing CT, while others only analyzed those with incidentalomas, which may skew the malignancy rate and follow-up outcomes. Thirdly, only a minority of the study reported malignancy risk stratified by nodule size. So it limited our ability to draw really firm conclusions about size-based risk. And finally, we lacked prognostic data. And none of the included studies reported outcomes like thyroid cancer specific morbidity and mortality. To summarize our findings, thyroid incidentalomas are relatively common findings on CT, and but overall they carry a low risk of malignancy. Despite this, follow-up is sometimes inadequate. For example, in some studies, fewer patients received ultrasound than the number of patients who had the nodules greater than 1.5 centimeter. Importantly, we found that larger nodules and younger patients are associated with higher malignancy risk, supporting the use of size and age as factors in triaging follow-up of CT thyroid incidentalomas. Our findings also point to several clinical implications. First, Future guidelines for CT thyroid incidentalomas should account for the higher malignancy risk seen in larger nodules in younger patients. Incorporating these risk factors may help refine which nodules truly warrant follow-up. Next, establishing a protocol that involves both radiologists and thyroid specialists, like what we do today, could help improve outcomes. And structured communication and shared decision making, I think they are key to ensure that high risk nodules receive appropriate follow-up without overburdening the system with low risk findings. Again, we have no disclosures. Thank you for your attention.
Thank you, Dr. Sung, for your presentation. We're now gonna proceed with Dr. Starc's discussion, and we'll come back to the discussion point in the Q&A at the end of his presentation. Dr. Starc.
Great. Let me share my screen. Okay, so you should be seeing my screen now.
Perfectly.
Thanks again for the invitation. It's a pleasure to be here and discuss a little bit. Hopefully I can kind of give a broader overview, and at least from the radiology perspective, how we think about some of these issues. And really, congratulations on the paper. It's a ton of data that you really, we can talk about it later, but some of the data is not so great, and some of the data is great. I think you really did a good job of picking out studies that come together and form a concise picture of what the problem is. And really, one of the strengths is it helps confirm some of these gut feelings that we have about thyroid cancer and about how we're treating it and how we're approaching it. And so let's step right in. I'm supposed to talk for 10, 15 minutes, but please interrupt if something comes up, and we can do it that way, or we can ask questions at the end too. So I wouldn't be a radiologist if I didn't show you a graph like this. CT's going up every year. This is 2016. It's still going up. And so with larger volume comes a ton more incidentalomas. And that's why I think this paper really works to help figure out what we're doing now. This is just a philosophical view from my view as the radiologist. We do want to sort of keep a balance, but thyroid has some particular characteristics that we want to detect anything as a radiologist. We have this fear of missing cancer. And we want to serve our surgical specialists because thyroid is surgically curable. So we have this real effort here to just find everything we can. And we end up sort of ignoring all the other things, the other side of the equation. So we're kind of skewed in that way. And I think your paper really helps us bring some things back into perspective. I will show some radiology images, don't worry. Why are we skewed this one way? Well, part of it is because the ATA says any radiographic abnormality, even suggesting a thyroid nodule incidentally detected, should get further workup. So that's some pretty good phrasing. I think Dr. Tuttle wrote that probably. The ACR tried to take a step back, made things more complicated as we often do. So we have this flow chart here. So we talk about suspicious findings, and I'll show you pictures of some of all these things. We try to ignore things if there are excessive comorbidities, which is the memorial excuse I get to use. And then we break things up by age and size. And this data came out of studies that were published earlier in that decade, really that show pretty striking variability in the size and survival and these risk categories. So the ACR tried to make it a little easier so we weren't doing excessive workups on every single thyroid thing we saw. Okay, sometimes it's easy. So here's our first set of images, axial and coronal CT. So this clicks all the suspicious buttons. So we have not even just a thyroid nodule, we have thyroid replacement with poorly defined margins invading everything around it. We have lots of helpful arrows showing you lots of lymph nodes. This is poorly differentiated thyroid cancer. We know this deserves workup. And then there's the other category. This is a young person with a nodule over 2 centimeters. They can feel this. Clinician can feel this. This deserves workup. caught on a chest CT in this case. This is a papillary. But then we're left with things like this. So which side is the thyroid cancer? We have 7 millimeter, both sub-centimeter. So obviously the one in the left lobe is more suspicious. It's got calcification. It's also in a bad spot, posterior near the tracheoesophageal groove where the recurrent laryngeal nerve hangs out. So this is the one that was biopsied as positive. The answer is these are unfortunately both papillaries. So there is a bucket of nodules that will not get categorized correctly. And that's the trick. So just back to the paper, the summary number for question 1, what is the prevalence that we detect? 8.3%. Really amazing work. Tons of patients we looked at. When I first saw that number, I thought that's kind of low. I'm definitely biased. I'm coming from a place where we look for cancer exclusively, and almost all the patients I look at have some sort of cancer. But I decided to just do a little me study, see how far off I am from the norm. So I just looked back at my last 50 cases quickly, and in 13 out of those 50, I was mentioning a thyroid nodule. So there's something I can detect. So that puts me at 26% rather than 8%. But I think your paper does a good job of explaining how that's possible. There's great heterogeneity in the data because there's heterogeneity in how these are acquired. I'm only looking at CT necks. I'm looking at things with contrast. I'm looking at all reformations, and I'm specifically looking for cancer on every patient. So this is one of your slides where this is the neck kind of studies, and versus the regular the other body images, and I'm more in the neck category, so that made me feel a little better, and makes sense. Here's just an example. You can take a brief look. Where's the thyroid nodule? You give contrast, it's a lot easier to see there's this isthmus nodule. So that's just, that's an illustration of one of the points that you guys brought up. You did the numbers really well. I do agree, there's a 46% that should get worked up technically, and we're only getting 35%, and maybe you can answer why you think that is at the end. And your question 2, or your primary endpoint, the risk of malignancy. This was very interesting to read because the numbers, even no matter how you tease them out, there's some variation here. It doesn't seem to matter so much what kind of study they're picked up on, which is at least good to know at some point. Really, there's no malignancies under a centimeter, which is reassuring, but we already seen in the real world that it can happen. And I'd love for you to talk about what do you think the differences and biases were to lead some of these numbers to be different. And just a little bit more discussion from my end. CT is good. It does have some particular problems that we run into even when we're looking for thyroid nodules that hopefully clinicians are aware of. Number one is we're usually think CT is better for the central compartment, but we do run into images like this where we have a bad bolus artifact from bad bolus timing. So this is intravenous contrast creating streak, and then we have streak from the shoulders as well, either due to the patient positioning or patient body habitus. And good luck trying to figure out if there's any central compartment nodularity in a case like this. And then one more example. We have dental artifact, of course. So where is the disease on this slide? If you're a thyroid specialist, you know where it's going to be because it's what I'm showing you. But this makes it a lot easier. Here's a PET CT, FDG avid nodule. And we do have tricks on CT. So this is the metal artifact reduction CT slice that's angulated a little differently to avoid the dental artifact. It's the same patient. And now you can put an arrow on it. Clearly see that there's this enlarged, enhancing lateral retropharyngeal lymph node. So that's just some things to be aware of, in addition to the stuff that you discussed in your paper, which is I agree with 100%. CT were mostly based on attenuation or density. And that misses, as we've shown, about half the nodules that you're going to have based compared to ultrasound. Our ultrasound has also gotten so good that it's gone beyond the spatial resolution. So we're going into the sub-millimeter category. So ultrasound is better at finding microscopic calcifications, pneumoma bodies, versus our CT coarse calcifications, which may mean something different. And better at seeing extranodal extension, better at seeing extrathyroidal extension, and those things. And the other thing is we have a problem in CT, no matter how we do it, non-contrast or what phase, or we don't know what the density means. We don't know if that means it's a cyst. We don't know if that means it's frank necrosis. We don't know if that means there's a solid component that's just a different density. And ultrasound is better at characterizing that. This is just some work, little work we did trying to figure out what necrosis, if we could correlate it, and we didn't have great success. The future, there's a lot of interesting things in the future. We can do different multi-phase. We can use radiomics. We could use AI. We could try to correlate with the genetics from tissue sampling. And I think those are all great, that are going to push our margins a little bit towards being more accurate. Is that going to replace some of the ways we treat these things? It's still to come. And none of these things are really going to apply to what we're dealing with. It's just the incidentaloma, studies done for other reasons. So for now, basically size remains king. I thought one of the limitations is actually one of the strengths here. I like that you captured as much of the heterogeneity as you can. And I just wanted to bring up, there's another side of the heterogeneity, is that there's a heterogeneity of radiologists reading this. And we're all in different settings. We have different priorities. This is just some of your data showing what their indication was as far as you could tell. And, a lot of these are for things that have nothing to do with thyroid. And if you're a radiologist that's reading trauma and you have 5 patients lined up outside the CT that are going to get scanned, vertex to pelvis, you're not going to spend very much time looking at the thyroid. Or if you're, in my world, if you're reading stroke codes and the cath lab is calling you, can we send this patient? You're going to be looking at the vessels and for hemorrhage and things like that. And the thyroid is going to be very low on your priority. So I think, yeah, exactly what you said. For prevalence research, the formal radiology review is required, because we're not all looking for the same things on every study. So, I mean, that was my thoughts. It's a great paper and mostly confirms what we're thinking. We can maybe tweak our prevalence numbers, and hopefully we inspire some future balance and how we treat these things in the future. So that was what my summary of everything was. I guess I can stop sharing.
Thank you, Dr. Starc, for your discussion. This is really interesting, and it brings a lot of insight and background into the problem. Before I go on to the questions, and I would also ask the audience to please send them in if you have any. I would like to go back to Dr. Song and Dr. Chen for final insights on your discussion and on questions about the paper.
I'll just say, Song did all the work on this paper with the help of some of the co-authors. So first of all, and he did a great presentation, which represents he did the work. And so I definitely want to make sure that he gets the credit for this. And I think he'd probably be the best person to answer any questions, since he knows the methodology and the analysis extremely well.
Thank you, Dr. Chen, for the recognition. It's really it's an honor to receive this comment from my mentor, and thank you again, Dr. Starc. It's really great to hear from a radiologist's perspective. I remember 2 of your comments. So one, is it really true that all nodules under 1 centimeter is not malignant? I agree. In real world, we definitely see some smaller nodules that are also malignant. And I think what we have in the study is some selection bias because although meta-analysis offers the benefit of incorporating different studies, but unfortunately we also lose the granularity. And my suspicion is there's some selection bias that in those incidentalomas, the nodules that were less than 1 centimeters are more prone to be missed or not reported by the radiologist. Oh, I'm not blaming the radiologist. I'm just saying that, it could be missed.
I
And the
agree.
second,
Even not reported, it wouldn't. We would just not even think of reporting it because we would just blow it off. Yeah, even if we saw it happens. Yeah.
um, and the second comment you made was so the subgroup analysis was the bias.
Mm.
So the way that we determined the level of bias was whether they had appropriate follow-up. So in some studies, they were like a brief studies performed during COVID period. So maybe the study started in 2020 and they like did a cross-sectional investigation 1 year later and they determined, okay, so let's go back to the EMR and saw how many patients had thyroid surgery. So that to me wasn't sufficient to know whether it's it's a cancer or not because maybe it was not followed up long enough, or a lot of patients haven't even scheduled their like thyroid workup. So we label these studies as low having high risk of bias. Mm, so we found what we found was that in studies have a more complete follow-up, these nodules incidentalomas tend to have higher risk of malignancy or a trend. Yeah. I hope I answered partly your questions.
Yeah,
Yes.
that's what I thought too. You particularly call, I think they're in the paper, it calls out two studies, and when you that were eliminated in the high risk uh, analysis, and those when I looked at those, yeah, they looked like basically they had no positive pathology. So that's either very short follow-up time or just not enough people got biopsies or something like that.
Yeah, I agree.
I wanna also congratulate you for the work that you put into to publish this paper, and I want to congratulate Dr. Chen for mentoring you and giving you all the credit. That is really an interesting and very valuable distinction. I wanted to ask you, when I was reading the paper initially, just as Dr. Stark mentioned, when I saw the risk of malignancy, it did seem low to me. But then when you start reading the numbers and you start looking at the sizes, as Dr. Starks also mentions, size is king. But when we look at the number of a sub-centimeter nodule, those nodules that we tend to ignore, or not ignore, but try not to overtreat or over follow, that the prevalence of cancer in those nodules is not zero. So is there something that you, Dr. Song, Dr. Chen, Dr. Stark, would feel like would be a finding in CT, I mean, that would warn you that something that you should follow, something that would make you warrant an ultrasound faster or go directly into biopsy? If it exists, is there something that you found other than the size and the age that you previously mentioned?
Yeah, CT is tough for sub-centimeter nodules. I showed you one case where there's calcification, and just particularly the location is I mean, at least in my practice, if there's something posterior near the tracheoesophageal groove, that gets treated differently than an anterior nodule, kind of no matter what the size is. But it's it's very hard to delineate extrathyroidal extension or irregular margins. The smaller the nodule is on CT, at least.
I see. So not characteristics, but how about location?
Yeah, I think that would be interesting to study. If radiologists made recommendations, even just based on location as well.
Because I asked because and I'm gonna go off in a tangent just for a little second.
Okay.
The Japanese groups, they have published studies on active surveillance, and active surveillance, speaking about those substance immunonodules that you can watch and those that are not the best candidates to have a conservative watch and wait kind of um, scenario. They mention location and proximity to certain structures. So that's and potentially lymph nodes. Is there something that you would look for? I'm speaking to the trainees in the audience. What should you look for to say, yeah, this is not the one you should joke about. Please take it to the ultrasound. Because in centers like yours, those patients most probably get an ultrasound before leaving the building. But mo in the community service, they'll get a CT and they'll be missed and potentially something that we should be looking for. What are your thoughts?
Yeah, it's a tough balance. I think if you have any heterogeneity to the nodule, and if you have a posterior location, that's something that should probably make your impression, shall we say, and then give the clinicians at least a heads up that there's something to follow here, at least. And the other things we talked about are the standard things. Yeah, if you see any suspicious lymph nodes, by which we mean the lymph nodes with calcifications, lymph nodes with hyperenhancement or heterogeneous enhancement. And then, of course, we said size is king, and thyroid nodule size is not great for thyroid lymph nodes. But there are some published guidelines, 1 centimeter short axis for non-level 2A lymph nodes is a pretty rough characteristic, but it will capture the abnormal ones most often. But when you're dealing with thyroid cancer, the lymph nodes are often smaller, but you can still tell they're abnormal because of their calcification or their hyperenhancement. And the other thing for the trainees is to learn the pattern of, for classical papillary thyroid spread of lymph nodes, is you want to check the central compartment, even though potentially the surgeon is going to check that in the OR anyway. Start there, and then start with your adjacent level 4 lymph nodes and sort of crawl up the neck and see if there's a logical pattern of spread on the ipsilateral side to help define whether you think those lymph nodes are normal or abnormal. So those are just some quick thoughts. I'd be interested to hear what the surgeons think about. Or even one of my questions was, with this information, does this help you? How would you approach your communication with your radiology department? Would you ask for more information in your incidental thyroid reports, or less, or where does that come from the clinician side? Are we reporting too much or not enough?
Dr. Chen?
Well, I would say that first of all, as you know, the volume is high, and we're not the ones typically that are getting these scans. They're typically like medical oncologists doing screening or other modalities that we're getting CTs for screening different things. So we're not the ones ordering it and getting the reports typically.
Yeah.
And so often, when we're asked to see them, all this action has already happened. Either they've, or and the song points out in some cases nothing happens to them because the report is issued and no one follows up on it. So you have both sides of the spectrum. As we know, there are a lot of even thyroid cancers that go undiagnosed, undetected, and patients are fine. So I think there has to be a balance of how aggressive we go after all of these. It's interesting because we have, at our place, we've started an adrenal incidentaloma clinic where we use some AI. We do this in collaboration with a radiologist, where they are able to identify through scanning a program that scans all the reports that are issued by radiology, patients who have an adrenal incidentalloma, and then their names get put in a database where we have a nurse practitioner that goes through them and then calls patients and follows up with them. And we have found a significant number of patients with undiagnosed adrenal disease. Now, if we did that with thyroid, we would be overwhelmed, right?
Yeah.
So I don't know what the right balance is to, do you like do more detailed reporting and then recommendations that suggest more action? I don't know what the right thing is. I'd be interested in see what Dr. Shaha would say about that.
Thanks, Herb. First of all, I would like to congratulate Dr. Song and Michael. You did a fantastic job on your commentary. I think that was very succinct and to the point. Another thing, I just want to congratulate Herb for developing one of the best endocrine program in the country. And what is more interesting for the audience is Herb is one of the chairmen who pushes his juniors, the medical students, the residents, researchers, everybody to work hard and publish enormously. If you look at his publications, a bulk of them come from the junior fellows, and he gives them full credit. This is unique, Herb, and you may not appreciate, but somebody like me who is in academic surgery appreciates it very much. Coming back to the incidentalloma, back in about maybe 20 years back at Memorial, we wrote a paper on PET incidentalloma. And we use that word PET incidentalloma because that was very common at Memorial. We had two PET scanners, and you couldn't see me for consultation without getting a PET scan. You walk in, the security guard will say, go and get a PET scan, then go and see Dr. Shah. So that was very common, and we used to find a fair number of PET incidentallomas, and we developed a practice that we would act only on those where we think the previous cancer is well controlled. We see a fair number of patients with advanced breast cancer, advanced lung cancer, and PET incidentalloma. Actually, we wrote a paper about maybe 15 years back, PET-associated incidental neoplasm. We called it pain at that time. The short form was pain. And it is really a difficult problem when we get these reports. What do we do about it? And I think Michael said it very well, that many times the radiologist is more concentrating on something more important. If the CT scan is done for the lung cancer, he's not going to spend enormous time on specifying what the thyroid looks like. Now, it is not uncommon that next year you do the CAT scan and he will write the thyroid is mildly enlarged, which was seen last time. And the patients read these reports. The problem is patients read the report in detail and they start challenging us why this was not picked up last year. And it becomes a little bit emotional many times when these questions come to the clinician. So my general philosophy is, I look at the CAT scan myself. If there is anything suspicious, I'll do the ultrasound follow-up. If there's nothing suspicious, just like a nodular goiter, I would just tell the patient your thyroid is slightly enlarged. Let's see next year or 2 years from today, or get an ultrasound as a baseline. The problem with the ultrasound is if the ultrasound shows a nodule, then you're kind of committed to do the biopsy. Once you do the biopsy and comes back as Bethesda 3 or 4, then there is an enormous involvement. So this is an unending problem. I don't think, and Herb, you said it very well. We don't know the right answers, but the clinician should use his judgment based on what he feels, what the patient has presented for, and what are the other issues. I just want to add one more thing in last 1 minute, that I use CAT scan for thyroid cancer routinely. I think it helps me to guide myself preoperatively the extent of the disease, the paratracheal lymph nodes, the lower extent of the disease, extracellular extension, and one more thing, is there retroesophageal innominate artery, arteria lusoria. And I think the radiologists at our place are very good in reporting that. So I am familiar with a non-recurrent nerve on the right side. So I think those are my personal beliefs. I don't think we have a right answer, but once the radiologist reports there is a thyroid enlargement or nodularity, the minimum we are entitled to do or we should do is a good ultrasound, which we can tell the patient that everything is fine. Let's see you in 3 years.
That is really interesting. Thank you, Dr. Shah, for that comment. All of it. I think we're gonna be facing ourselves in a situation where this is gonna be if I may use the word, a pandemic where AI assisted image review will pick up smaller things that we will not know how to treat. Balance, as Michael said before, will be key. And going back to the paper, I can't congratulate Dr. Song more for his endeavor and his effort. Systematic
Thank you.
reviews in nature are like that. You will report what the literature says, and you will filter and give the best answer the question the best you can. But there's so many nuances into how a thyroid nodule will show you and present to you. So your words, Dr. Shahan, and your expertise on how you treat and how you use CT are valuable. And I think trainees and us that are growing in thyroid nodule assessment value that a whole bunch. There's a couple of questions, and I'm gonna just uh, take the advantage that you were mentioning PET incidentalomas. There's a couple of questions from the audience. One of them is, why were PET CT incidentalomas left out in the study? That'll be a question for Dr. Song. And then following up to that, Dr. Pinner-Smith, she was asking, can thyroid cancer be both radioactive iodine avid and PET avid on imaging?
I will take the first. Sorry. So thank you for the question. Why was the PET incidentalomas left out? It was because there was previously some good papers reporting the prevalence and risk of malignancy in those PET avid incidentalomas. So what we do in this paper is just focusing on the CT incidentalomas. But great question. Thank you.
Thank you.
I'm not a nuclear medicine imager, but in terms of, yes, things can be iodine and FDG avid, but they tend to fall on a spectrum of either one or the other. And as the thyroid de-differentiates or becomes more aggressive, it tends to become more FDG avid and with less iodine uptake. That's
Thank you.
brief too.
One quick question for Dr. Song. Is there a way, and I know you're limited to the data that you have, and as you said in systematic review, you lose granularity of the data. Is there a way to back engineer to see those patients that were followed up, that had biopsy and potentially had surgery, and those that you are certain that were cancers? Is there a way to back engineer what kind of features they've showed in CT? Or is that too specific of a question to ask?
Thank you, Dr. Gonzalez. I think that would be a really good approach. So the way that we did our analysis is to look at their tables, which is a aggregate of all patients. So if we were going to try the back engineering, we'll need a more detailed table than
Got it.
the data that was presented in the original paper. But
Beautiful.
yes, we can if we can request the original data.
That'd be something that would shine a little bit more light to what we have right now and try to keep
Yes,
or seek that balance that Dr. Starc was mentioning. We're right
I
now
agree.
about to hit the hour. I don't want to miss the opportunity to thank all of you for your time, for your effort, for your paper. I want to invite everyone to come back next week. Next week we will have tumor board where we have Dr. Mike Tuttle moderate an international tumor board and forgive us for the mistake. The case presenter will be Dr. Nicolini from Mexico City, presenting 3 interesting cases of advanced thyroid cancer. So we hope to see everybody back next week, and we hope you have a great weekend.